All right, so we are talking congestive heart failure in this webinar. So, congestive heart failure, I'm going to abbreviate it as CHF. You will hear that in practice all the time. What symptoms result from CHF and what are some of the characteristics? So, what's happening is basically the heart is lacking the ability to effectively pump blood, and so that's going to naturally impact that circulation. From a lab standpoint, we can have an elevated BNP, so that's an important thing to note, or an elevated pro-BNP. Shortness of breath, coughing, fatigue, weakness, and this congestion and swelling all throughout the body can happen as well. And the most common type of heart failure is heart failure with reduced ejection fraction, and that's designated as HFrEF. Staging, I'll just throw this out there, but obviously patients can be pretty much asymptomatic in mild cases, and then even at rest, patients can have symptoms, and that would be the most severe type of staging there. But we've got two different classifications there. You can just glance at that for your reference. All right, medications used in heart failure. So again, this is reduced ejection fraction heart failure. The four classes of what's called guideline-directed medical therapy, or GDMT, in HFrEF involve RAS system medications. So that's typically going to be your ACEs and ARBs, those type of things. SGLT2 inhibitors, beta blockers, and mineralocorticoid inhibitors. And I'll go through of these, each of these individually coming up here. But it's often called quadruple therapy. So historically, it used to be ACEs and ARBs, which I covered in the hypertension section. But more recent guidelines have embraced ARNI as a more effective option, and I'll discuss that coming up here. Then we've got beta blockers, again, covered that in the hypertension section. SGLT2 inhibitors, I'll cover them briefly, but these are actually originally studied as a diabetes medication and can lower blood sugar. And then we've got mineralocorticoid receptor antagonists. Okay, these are also called aldosterone antagonists, and spironolactone is going to be the most common medication there. So those are kind of the four mainstays, but most patients with heart failure will be on some sort of diuretic as well. And typically the most potent diuretic we have are loop diuretics, but you also may see thiazide diuretics and potassium sparing diuretics as well, which are analogous with MRAs. All right, so let's dig into the meds here a little bit more specifically. So we've got the ARNI classification, and right now we only have one medication within this drug class. This is a combination of an angiotensin receptor blocker, so that would be an ARB, like losartan, valsartan, those type of things, and a neprilysin inhibitor. So the only combination we have is with valsartan, that is the ARB there, and sacubitril is the neprilysin inhibitor. Now, the guidelines recommend this is a first-line therapy. Reduces morbidity, so that's symptomatology of heart failure, and it also has been shown to reduce mortality, so extend life expectancy there. Evidence is greater in specific subsets. In most patients with HFrEF, the evidence is better than just using an ACE inhibitor or an ARB alone. But cost is also a potential issue with this medication, as it can be expensive at this time. I've spent over a decade teaching pharmacology, and I hope you enjoy this review and find it helpful in your studies. You can get full ad-free access to the MedEd 101 Nursing Pharmacology Review course at meded101.com/nurse. In addition, you'll get nearly 20 hours of ad-free, on-demand video lessons, downloadable slides which you can study from, over 40 cheat sheets and study guides, and practice questions to assess what you know. Whether you're preparing for exams or building real-world confidence, this course is designed to teach you things that matter on the test and in practice. Help support me in my mission to provide free, high-quality pharmacology education. You can do that by going to meded101.com/nurse and checking out the MedEd 101 Nursing Pharmacology Review course. So more specifics on the pharmacology here. So naproxen breaks down atrial and brain natriuretic peptide. So brain natriuretic peptide, that's BNP. That's a lab we can assess as well. Ultimately, through this pathway, this leads to lower blood pressure and increase in fluid loss. Remember, in CHF, we have fluid excess typically, so this medication is going to help with that. Now, the combination with valsartan and sacubitril, it tends to lead to a greater reduction in blood pressure than just ACE or ARB alone. So we've got to be careful with that. Obviously, we're going to be closely monitoring blood pressure in our heart failure patients. Avoid in patients with a history of angioedema. Remember, that's that swelling of the lips, tongue, and if severe enough, can swell up the throat and cause acute, emergency type difficulties in breathing. Important thing to note when switching from an ACE inhibitor to the ARNI, there is a recommended 36-hour washout period. And that is due to the risk of angioedema if they are taken together or taken too closely together there. And I've laid out the dosing for your educational purposes there as well. One downside is it is twice daily dosing with this medication. Beta blockers and ACE inhibitors, and I would guess I would include in ARBs here. So ACE or ARBs are an alternative to ARNI. You would never use them together. Remember, the ARNI medication has an ARB in it already, just combined with the sacubitril. So don't ever use those together, and you shouldn't see that in practice. Beta blockers, we do try to kind of push the dose with beta blockers, but recall that they can lower pulse and heart rate. So that's typically what we're looking at, and they can induce fatigue as well. So while we try to push that dose, that can be challenging in our elderly patient, falls, weakness, those type of things. The most commonly used beta blockers are metoprolol succinate and carvedilol. Those are the ones that you're going to see in practice most often in patients with heart failure with reduced ejection fraction. All right, so the SGLT2 inhibitors, dapagliflozin, empagliflozin, those are the most common agents you're going to see utilized there. Brand name is Jardiance of one of those medications there. Farxiga is another one. Now, these drugs have shown benefit in heart failure with reduced ejection fraction, even in patients without diabetes. Okay? So, if we've got a patient with diabetes and heart failure, definitely makes sense to use an SGLT2 inhibitor. That's definitely going to be a no-brainer there for sure. One other subtype of heart failure, we've got heart failure with preserved ejection fraction. SGLT2s are a very, very important and beneficial medication here. And I'm going to, cover the mechanism and how this medication works in much, much greater detail in the diabetes section. Important things to think about: they can have a mild diuretic type effect. Obviously, they're going to lower blood sugar, so that is something that we may monitor, and this is especially important if you've got a patient that's, taking insulin or another medication that may increase the risk for hypoglycemia. And mechanistically, basically what SGLT2s do is they kick out blood glucose out through the urine. And so what that does is that allows a food source for urinary tract bugs and infections, okay? So when we pump glucose out through the urine, all of a sudden, if we've got, bacterial growth and those type of things, yeast infection, we've got a source of food essentially for those bugs. And so there's an increased risk of genitourinary infections with the SGLT2 inhibitors. So that is definitely something to pay attention to and monitor in patients taking these medications. Now we've got aldosterone antagonists. They can definitely be used for heart failure as well. Spironolactone, I've laid out, I believe, the mechanism of action in the hypertension section, but I've laid it out there as well. Potassium and renal function, super important to monitor with the use of spironolactone. And remember, spironolactone can also cause gynecomastia, so basically an enlargement of the breast in males, or some tenderness and those type of things too. All right, moving on to loop diuretics. Furosemide, brand name Lasix, that is by far the most common loop diuretic I see in practice. Occasionally I see some torsemide, occasional bumetanide as well. Mechanistically, this inhibits the reabsorption of sodium and chloride in the ascending loop of Henle. So this is in the nephron of the kidney. So these drugs work in the kidney. And when we don't have that reabsorption of sodium and chloride, that goes out through the urine, and it also brings out water with it. Okay? So this can dramatically reduce electrolytes and cause significant dehydration. So hypokalemia, hypomagnesemia, very, very common that it can cause this. And that's why we monitor renal function. That's why we monitor electrolytes with this medication. Probably the most common adverse effect and the most complained about adverse effect by patients is this medication is getting rid of water out through the urine. So naturally, patients are going to have to go to the bathroom more. And this can be really problematic at night and, interrupt sleep and those type of things. So typically, we're going to dose most of the doses of loop diuretics at noon or before. Maybe 1 or 2 p.m. in rare cases, but typically most of the dosing of loop diuretics is going to come earlier in the day, so patients aren't getting up at night. Ototoxicity, so that's ear toxicity and hearing changes, impairment, and loss. That is a possible adverse effect. It's very rare, and usually it's with excessively high doses. Thiazide-like diuretics, metolazone. I've seen this used in combination with loop diuretics to kind of give an added boost to fluid loss. Mechanistically, it inhibits sodium and chloride reabsorption in the distal convoluted tubule of the nephron, again, working within the kidney. Again, being a thiazide-like diuretic, it's in the same class as hydrochlorothiazide and chlorthalidone. But metolazone may tend to work a little bit better as kidney function declines. Super, super important to recognize that electrolytes should be monitored closely when this medication is added. Again, particularly with the use of loop diuretics, they can cause a profound drop in electrolytes, and I would say specifically potassium. Okay, so very, very important to monitor electrolytes when this medication is added, just like when loops are added as well. Also can increase uric acid, so pay attention to that. It may exacerbate gout in that situation. Digoxin and CHF, I covered this in atrial fibrillation. Isn't used very often anymore for CHF. We've got a lot of other medications that we can use. There isn't any proven mortality benefit. It doesn't extend life at all. There's maybe just some potential benefit in morbidity and symptoms. Again, not used very often. If we do it, we target drug levels there. And again, I'll refer you back to atrial fibrillation for some of the toxicities and those type of things. All right, I do want you to know some classic medications that exacerbate CHF. So asking about over-the-counters is super important. NSAIDs like ibuprofen, naproxen, these can cause sodium retention, increase the risk for heart failure exacerbation. In addition, NSAIDs can exacerbate kidney damage. So when we're talking about having diuretics and ACE inhibitors and ARBs on board, that's a big deal. So we got to monitor renal function, and if we can at all do anything, we definitely want to avoid the use of NSAIDs in our patients with CHF. Calcium channel blockers like amlodipine can worsen edema, which may already be problematic in our CHF patients. TZDs, so this is a class of medication used for diabetes, pioglitazone being the classic example there. They can worsen edema. Pregabalin can as well, and cilostazol, which is a rare medication used for peripheral vascular disease and symptoms of intermittent claudication. All right, important monitoring from a nursing standpoint. So we're going to be looking at their breathing, shortness of breath, respiratory rate, lung sounds. We can get some congestion, obviously. Oxygen saturation, making sure that tissues are being adequately perfused and we're able to deliver oxygen as we need it. Blood pressure, heart rate, obviously that's a no-brainer with all the blood pressure meds that we're utilizing there. And then heart rate, we've probably got a beta blocker on board potentially. Daily weights, so that's going to be monitoring for fluid retention there. Water, urine, intake, output. Definitely important to monitor that as well. And then from a lab standpoint, that BNP, typically in a heart failure exacerbation, is going to be elevated, so that may be something that we're looking at there. And then, of course, electrolytes, super, super important. I've seen tons of cases of hypokalemia, dropping those potassium levels too far with those diuretics. So we may need to certainly do potassium replacement and give potassium supplementation. And then, of course, lastly, renal function is very, very important as well. Diuretics, ACE inhibitors, ARBs, they can all induce acute renal failure. So we need to make sure that creatinine isn't rising too quickly. Hey, nurses and nursing students. Want to reinforce pharmacology without boring old flashcards? Check out the Nursing Pharmacology Crossword Puzzle book from MedEd 101. It's an Amazon bestseller. It turns drug classes, mechanisms, side effects, and high-yield facts into fun, brain-boosting puzzles that help you remember what matters most. With over 2,000 questions and clues, it's perfect for study breaks, group review, or solo practice. This book makes learning pharmacology engaging. Grab your copy and start mastering meds in a way that's actually fun. Find it now at meded101.com/nurse. That's meded101.com/nurse.